Good day. So again, welcome to Clinical Pharmacy and Pharmacotherapeutics 2, Gastrointestinal System Therapeutics. For our disclosure and disclaimer, the content presented in this YouTube video contains pharmaceutical lectures that are solely for educational purposes and does not intend to provide medical advice. The information provided in this video is based on standard references, reputable sites, and updated guidelines. This lecture is not intended to replace professional medical advice or treatment. Viewers are advised to consult with their healthcare provider before making any medical decisions or changes to their treatment plan. The lecturer does not receive any compensation or financial benefit from the mention of any proprietary products or devices in this presentation. Any reference to such products or devices is purely for educational purposes and does not imply endorsement or promotion. By watching this video, viewers acknowledge that they are responsible for their own health decisions and that the content presented is not a substitute for professional medical advice or treatment. The lecturer and YouTube channel do not assume any liability for any damages or consequences arising from the use of the information provided in this video. So we are going to focus on the discussion on pancreatitis. So pancreatitis is defined as the redness and swelling or inflammation of the pancreas. It has two types. We have the acute pancreatitis or AP and chronic pancreatitis or CP. Acute pancreatitis is an inflammatory disorder of the pancreas characterized by upper abdominal pain and pancreatic enzyme elevations. On the other hand, chronic pancreatitis is a progressive disease characterized by long-standing pancreatic inflammation leading to loss of pancreatic exocrine and endocrine functions. Now, what you can see in your slide is a pathogenesis of acute pancreatitis. So let's take a closer look. So acute pancreatitis, the pathogenesis and clinical findings. So what are important things to note? First, it is not enough to just diagnose the acute pancreatitis, but we need to look at the full management requirement that determines the underlying etiology with further workup. Now, there are several factors or etiologies contributing to the formation of acute pancreatitis or development. We have alcohol, gallstones, hypercalcemia can also be considered, although rare, hypertriglyceridemia, and of course, idiopathic mechanisms or unknown mechanism. So let's look at alcoholism. For alcohol, this would increase the toxic metabolites within the pancreas and the sphincter of Oddi spasms. This will lead to pancreatic secretions, backup, and increased pressure within the pancreas. For gallstones may migrate to common bile duct, blocking the sphincter of Oddi, providing or leading to the same effect of increasing pancreatic backup and pressure. Hypercalcemia, as I've mentioned, although rare, the calcium depositions, or rather the calcium deposits in the bile ducts that eventually blocks the outflow of the pancreatic secretions. Now, it should be noted that associated signs due to intra-abdominal hemorrhage from an unknown mechanism, which is classically associated with pancreatitis, that happens is less than 1% of the case. We have to look at the Cullen sign, which is bruising in the periumbilical region, and the Gray-Turner sign, which is the bruising along both flanks. So going or following this diagram, all of those mechanisms will lead to pressure compression of the pancreatic blood vessel, causing tissue ischemia, and then the activation of inactive proteases or zymogens digesting pancreatic tissue. Now, this will lead to necrosis or the death of the pancreatic cells, and eventually to massive systemic inflammatory response. Now, the inflammatory response are self-perpetuating. Furthermore, there are several occurrences that will follow which are associated with the signs and symptoms, such as since the pancreas is retroperitoneal, some somatic nerves in the parietal peritoneum are directly stimulated, leading to sudden severe epigastric pain with peritoneal signs that radiates to the center of the back. There would also be triggering of the cytokine release, causing fever, nausea, and vomiting. Inflamed pancreas would further irritate the adjacent intestines, especially causing ill use. That's why there are diminished bowel sounds. And inflamed, more permeable blood vessels leak fluid into the pancreas, leading to profound dehydration. Now, furthermore, the massive systemic inflammatory response will either lead to pancreatic pseudocysts or enlargement of the pancreas due to fluid accumulation or pancreatic necrosis and abscesses, which basically is the death of the part of the pancreas. So the pancreatic pseudocysts will lead to two main complications which can be detected by CT, but other laboratory tests are also recommended. Now, these are a list of medications associated with acute pancreatitis and their association. For class 1, this is definite association, such as in the form of corticosteroids, cytarabine, enalapril, sulfasalazine. For probable association, acetaminophen or paracetamol, erythromycin, interferon, lamivudine. And for class 3 or possible associations such as amiodarone, calcium, we have pravastatin, salcitabine, and the rest. Now, for clinical presentations, there is noteworthy uh, clinical presentation differences with AP and CP. For the initial presentation of AP, this will range from moderate abdominal discomfort to excruciating pain, shock, and respiratory distress. Abdominal pain occurs in 95% of the patients and is usually epigastric in nature. It usually radiates to the upper quadrants and to the back. Onset is usually sudden and intensify is often described as knife-like or boring. Pain usually reaches maximum intensity within 30 minutes and may persist for hours or days. Nausea and vomiting occur in 85% of patients and usually follow onset of pain. Signs associated with widespread pancreatic inflammation and necrosis includes marked epigastric tenderness, abdominal distension, hypotension, tachycardia, and low-grade fever. In severe disease, bowel sounds are diminished or absent, just like what we have mentioned in our diagram. And dyspnea and tachypnea are signs of acute respiratory complications. Now, for the chronic pancreatitis, the main features include abdominal pain, malabsorption, weight loss, and diabetes. Jaundice usually occurs in 10% of the patients. Patients typically report deep penetrating epigastric or abdominal pain that may radiate to the back. Pain often occurs with meals and at night and may be associated with nausea and vomiting. Steatorrhea and azotorrhea occurs in most patients. Steatorrhea is often associated with diarrhea and bloating, and weight loss may also occur. Pancreatic diabetes is a late manifestation commonly associated with pancreatic calcification. So for the diagnosis, the recommendations for AP and CP are also different. For AP, diagnosis should be made within 48 hours based on characteristics of the abdominal pain and elevation of enzymes such as amylase, lipase, or both to at least 3 times the upper limit of the normal. CECT or the contrast enhanced computed tomography of the abdomen may confirm the diagnosis. Magnetic resonance imaging and ultrasonography can also be useful. Now, AP may be associated with leukocytosis, hyperglycemia, and hypoparathyroidism. albuminemia. Hepatic transaminases, alkaline phosphatase, and bilirubin are usually elevated in gallstone pancreatitis and in patients with intrinsic liver disease. So marked hypocalcemia indicates severe necrosis is a poor prognostic sign. Now, serum amylase usually rises 4 to 8 hours after symptom onset. So it peaks at 24 hours and returns to normal over the next 8 to 14 days. So concentrations greater than 3 times the upper limit of normal are highly suggestive of AP. Now for the serum lipase, this is specific to the pancreas, and concentrations are elevated and parallel the serum amylase elevation. Increases persist longer than serum amylase and can be detected after the amylase has returned to normal. Now, for hematocrit, this may be normal, but hemoconcentration results from multiple factors. Hematocrit greater than 47% predicts severe AP, and hematocrit less than 44% predicts mild diseases. While C-reactive protein levels greater than 150 milligram per deciliter at 48 to 72 hours predict severe AP. And also, we need to take note of thrombocytopenia and increased international normalized ratio. So INR. So this can occur in some patients with severe AP and associated liver diseases. Now for chronic pancreatitis, diagnosis is based primarily on clinical presentations and either imaging or pancreatic function tests. So non-invasive imaging includes abdominal ultrasound, CT. You can also have MRCP. MRCP is magnetic resonance cholangiopancreatography. And for EUS, that's for our invasive imaging, we can have EUS or rather endoscopic ultrasonography, and ERCP, which means endoscopic retrograde cholangiopancreatography. Similar, serum amylase and lipase are usually normal or only slightly elevated, but may be increased in acute exacerbation as compared to AP. We also have to look at total bilirubin, alkaline phosphatase, and hepatic transaminases, which may be elevated, especially with ductal obstruction. Serum albumin and calcium may be low with malnutrition, and pancreatic function tests should also be taken, which include serum trypsinogen, which is less than 20 nanogram per ml. That's the abnormal level. Fecal elastase, an abnormal level will equate to less than 200 microgram per gram of the stool. Fecal fat estimation, more than 7 grams per day, is abnormal, and the stool must be collected for 72 hours. Secretin stimulation, this would evaluate the duodenal bicarbonate secretion and the 13C mixed triglyceride breath test. For goals of treatment for acute pancreatitis, our goals would include relieve abdominal pain, replace the fluid, correct electrolytes, glucose, and lipid abnormalities, minimize systemic complications, and prevent pancreatic necrosis and infection. So with this, our algorithm would include in acute pancreatitis. If it's a mild disease, this is a favorable prognosis, meaning normally it has no systemic complications. The treatment would have supportive care, analgesics, and nutrition. Now, if it is in the severe disease, this would lead to unfavorable prognosis and usually leads to systemic complication. So it can either be interstitial or necrotizing. For interstitial, intensive care is required, so we need to have the patient admitted in the hospital. Fluid resuscitation, we need to address the systemic complication or systemic effects, ERCP of the gallstones, and parenteral-enteral nutrition, and consider octreotide. For necrotizing, it will always also be almost similar, but we have to add antibiotics. So further, for necrotizing, if there's improvement, we just need to continue the treatment. If there's no improvement, we have to rule out infected pancreatic necrosis. If infected, surgical debridement is needed. And if sterile, we just need to continue the treatment. So for non-pharmacological option, for AP, nutrition support is very important because AP creates a catabolic state that promotes nutritional depletion. So patients with mild AP can begin with oral feeding when bowel sounds have returned and pain has resolved. But nutritional support should begin when it is anticipated that oral nutrition will be withheld for longer than 1 week. So we can have enteral feeding as preference over PN in severe AP if it can be tolerated. So remember the general rule, if the gut works, utilize it. If not, we can resolve to parenteral nutrition. So you should also note that in parenteral nutrition, it should be started prior to protein and calorie depletion. Now, ERCP or endoscopic retrograde cholangiopancreatography is performed to remove the biliary tract stones, and surgery is indicated in patients with pancreatic pseudocysts or abscesses. Also to drain in the pancreatic bed any hemorrhagic or necrotic material if present. For the pharmacological treatment, patients are treated with IV antiemetics because they would manifest with nausea. So patients with severe AP should be treated with anti-secretory agents to prevent stress-related mucosal bleeding. Appropriate fluid resuscitation and pain management are also necessary. So parenteral opioids are also given to control the abdominal pain. So morphine is often used in patient or PCA, patient-controlled analgesia, should be considered for those who required frequent opioid dosing. So meperidine is no longer recommended as a first-line agent because of its adverse effects that would include seizures and some dosing limitations. There are insufficient data for the use of somatostatin or octreotide for treatment of AP, but nonetheless, evaluation should be considered. And then for prophylactic antibiotics, they usually have no application if the patient is on mild AP or if there are no necrosis. Again, we look at the algorithm. So the use of antibiotics is commonly in severe AP with or without necrosis. So the use of antibiotics in necrotizing AP is only recommended in the presence of known or suspected infections. Surgical debridement is required once the infection is develops, and we have to consider the spectrum of the antibiotic. So commonly should cover the enteric aerobic gram-negative bacilli and anaerobic organisms. And the antibiotic should be started within 48 hours and continued for 2 to 3 weeks when infection is still present. So for this, imipenem cilastatin, usually at a 500 milligram IVQ8 has been widely used, but you need to assess the resistance and susceptibility. In some formularies, carbapenem, such as meropenem, is already being used. For fluoroquinolone option, such as Cipro or Levo, we can combine with metronidazole, but it should be considered for penicillin allergic patients only. So in patients, again, it is important that in acute pancreatitis, we have to evaluate the existing signs and symptoms and manifestations for the patient and how we can address them. So for the algorithm for chronic pancreatitis, so if the patient has malabsorption or steatorrhea, begin pancreatic enzyme supplementation at 25,000, 40,000 units per mil. If there's improvement, we just continue the treatment. If none, we decrease dietary fat to 0.5 gram per kilogram per day. We again evaluate for improvements. If the treatment is good, we just have to continue it. If no improvement is observed, we increase the enzyme dose to a maximum of 75,000 units per mil. For improvement, continue the treatment. If no improvement, we can opt to add histamine 2 receptor antagonist or PPI. For the goal of treatment, we relieve the abdominal pain, treat complications of malabsorption and glucose intolerance, and improve quality of life of the patient. Meaning to say, we need to prevent any untoward or further side effects. For non-pharmacological options in CP, a lifestyle modification should be advised, and this would include abstinence from alcohol and smoking. Advise patients with steatorrhea to eat smaller, more frequent meals and reduce dietary fat intake. So these are diet changes. Patients who do not consume adequate calories from their normal diet may be given whole protein or peptide-based oral nutritional supplements. And invasive procedures or surgeries are used primarily to treat uncontrolled pain and the complications of chronic pancreatitis. So for the pharmacologic option, pain management should begin with oral non-opioid analgesics such as acetaminophen or paracetamol, and we can also opt for non-steroidal anti-inflammatory drugs. And this should be administered on a scheduled basis before meals to help decrease the postprandial pain. So, pancreatic enzyme supplementation for pain relief may be given prior to adding the opioids. Now, if these measures fail, we can add low-potency oral opioids such as hydrocodone to non-opioid analgesics. Eventually, we can also use tramadol. And then for severe pain unresponsive to these therapies, we can opt for opioids such as codeine, morphine sulfate, oxycodone, or hydromorphone, unless they are contraindicated. First, also remember that we need to maximize first the oral opioids before we consider parenteral, transdermal, or other dosage forms. We can also add, especially in patients that has wherein the pain is difficult to manage, we can consider non-opioid modulators of chronic pain, such as pregabalin, selective serotonin reuptake inhibitors, and tricyclic antidepressants. But again, we first have to evaluate if that would be very applicable to the patient, meaning the benefit outweighs the risk. For pancreatic enzyme supplementation and reduction in dietary fat intake, primary treatments, these are the primary treatments for malabsorption. So this basically enhances nutritional status and reduces steatorrhea. For adverse effects of these supplements, they are usually benign, but high doses can lead to nausea, diarrhea, and intestinal upset. You should also consider evaluating possible deficiencies in fat-soluble vitamins. And we need to monitor vitamin D. So we need to add H2RA or PPI if we need to increase the effectiveness of the pancreatic enzyme therapy by increasing gastric and duodenal pH. That's all. Thank you.